Morning, good afternoon, wherever you are joining us today. Welcome to the latest webinar from the Asian Pacific Society of Cardiology in collaboration with the Transcontinental Coronary Imaging and Physiology Club. Today's theme will be the use of intravascular imaging and physiology in bifurcation PCI. Today's webinar is endorsed by the Singapore Cardiac Society, also accredited by the European Board for Accreditation of Continuing Education for Health Professionals, and we are thankful for the support of Abbott Vascular. Now, joining me in moderating today's session will be Dr. Thomas Johnson from the United Kingdom and Dr. Frankie TAM from Hong Kong. And we have a long and illustrious list of speakers and panelists. We'll introduce each of them just before they speak. As you can see, they're all from a truly transcontinental feel to the speakers and panelists. So on the panel, we have Professor Jack Tan from Singapore, Dr. Sydney Loh from Australia, Dr. James Chee from Australia as well, my mentor and good friend, Dr. Akiko Maehara from New York, United States, Dr. Vincenzo Vizzi from Italy, Dr. Yongchul Kim from Korea, and Dr. Jonathan Sung from Hong Kong. Just a few housekeeping notes before we start. The content of this webinar is copyrighted to the APSC, and all the views and opinions you hear today are those of the faculty members and do not necessarily represent those of the APSC. This webinar is live streamed via Wonder, APSC Facebook and YouTube pages. CME points will be submitted for those who are connected through the whole duration of the webinar, and you will receive your certificate of attendance upon completing a survey sent via email after the webinar. And if you have any questions during the at any point during tonight's or today's session, please click the Q&A button and type in your questions, and we'll either answer them live or via a reply in the chat box. Just a quick plug for the next webinar, APSC webinar. This will be on the 27th of April, and the theme for that one will be APSC Emerging Acute Heart Failure Series. Teaching moments in heart failure. So without further ado, let's get started. We've got a packed program for today. And our first speaker, I'm very pleased to invite is Dr. Merida CADENAS from Spain. And she will speak on the role of physiology in left main and non-left main bifurcation. Please, Merida. Merida, yeah.
Yes, hello. Screen. Hello, everybody. I'm very happy to be here again with you. We're going to speak a little bit about the physiology in left main and non-left main bifurcations. So first we have to...
You go full screen first, Merida, if it's okay. Slide share. I mean full screen for the slideshow.
Let me see. Yeah, it's supposed to be full screen. Let me... Oh, I see. My goodness. Sorry, I can't find the way to put it on full screen.
Could you try to click the or press the F11 button on your keyboard?
Yeah. Is it now working?
Okay, maybe you try to share it again.
see. Can you see it now?
Okay,
Yeah, this is much better.
yes.
Yeah, good.
Great. So let's begin before further delay. So the first thing I want to call upon is the need that we have to use physiology to really evaluate the functionality and the real need to do and to perform PCR. We have also used imaging. We're going to talk about it later, and we have also used the coronary angiogram. But we have to remember that after all these lesions treated and studied via angiogram and IBUS, there was no correlation or exact correlation with what we have to deal with the side branch lesion in the terms of the impact in physiology and in the symptoms of the patient and the burden of ischemia. We have to know that the use of physiology in the PCI for bifurcations is to reduce the complications in the vessels that do not require revascularizations. And most of the time is to decide whether or not the side branch in the larger number of bifurcations that we deal in daily practice really needs to get a special treatment or another stent or a more complex technique. So we have to use them first to assess the functional significance of both branches, even that for the side branch it's not so fully or clearly understood how is the cutting point. We also have to determine if the side branch after we deal it is going to be necessary to perform further treatment and to evaluate the residual ischemia. It's important to remember that first we're going to address if the bifurcation that we're dealing with really needs complex techniques beyond the image of angiography. And then we have to realize if we can evaluate these results with physiology. Here is a very important publication about the consensus between the Asia and Bifurcation Club here in Europe. And it is important that if we see an image of a bifurcation that seems important and it correlates with patient symptoms or prognosis, then we have to go and add the technique that we think or consider important. And of course, we have to value their results, especially when using one stent technique with physiology to really have a very clear, practical and objective response to whether or not we need to put on to do another technique. So it's important that we remember that the presence of ischemia or low physiologic index, there's no guarantee that the revascularization that we do is going to be successful or beneficial in the terms, especially of the secondary branch. And we have always to remember that beyond the physiology, we have to pay really good attention if this territory that is nourished by this secondary branch will be important burden of ischemia. We already know that for being relevant, it has to claim clinical symptoms, it has to be potential for arrhythmic events, and it has to have an ischemic burden. We have to remember that only 1 in 5 no left main bifurcations, the secondary branch supplies more than 10% of the total myocardial territory. So if we decide to use a revascularization, we have to take into account for the side branch that sometimes the anatomical stenosis, it's not a mark of how functionally is going to behave this stenosis in this branch. We have to acknowledge also the downstream and upstream disease within the main vessel, and we are very much encouraged to perform a pullback along with the angio to see where the biggest step is regarding to this variation in the physiological index or the FFR. We have to remember that it does not predict the functional significance of the jail branch. It means that if we have a branch that it was not significantly important in terms of physiology before using or treating the bifurcation, it does not mean the ones that we have a jail branch who is pinched, it's going to be also insignificant. And we have to remember that sometimes we only have to do the Girona rearrangement after the shift or the plaque shift, meaning the pot or kissing, before evaluating if this significant branch, if this secondary branch has significant implications regarding the stenosis that we look. We have to remember that it's important that we address the physiology when it's a short lesion, an ostial lesion, and diffuse lesion. It's not so well established because we have the risk that really injure the vessel. In a tandem lesion, only to regard the jump or the step in the pulling back. And it's not recommended to use it in heavily calcified lesions or tortuosity. We have that validating the results of what we have. We have the validation of the functional status of the side branch once we have performed the initial stent treatment. We have to remember that if we do a kissing balloon or even the pot, this kind of inflation without further intervention, it will last at least 6 months to provide a good benefit in terms of physiological relevance. We can also use this. This was recently published, and it's very interesting because we can leave the pressure wire jailed within the side branch and do another measurement as a technique to really evaluate the result without further attempts to cross this stent. This was done. The damage, it was not clinically significant of this kind of wire. And it was important because the side branch interventions are less, and the results, whether done or not done, this more important approach or more complex approach to the side branch is of not need and did not change the result at 2 years. We have to really remember that if we are only looking at intercoronary image or angio image and try to address this side branch, we can have more events on the main vessel. So we have to always consider the clinical relevance, the additional procedure, and the value of this physiological index. This physiology is useful also to evaluate the result of a double stent technique, but it does not mean that the technique was successful in terms that we have to use always intravascular image to guarantee the good result despite the result that we may have with the physiological evaluation. In the left main, we have not yet validated radio for the instantaneous wave-free radio evaluation for the significance of the left main bifurcations. This was another study from the defined left main registry, and they were trying to assess whether with the instantaneous index we can have enough information to decide whether or not to treat and with what kind of treatment to use in these patients. And it was important that 5 years, they showed that it was a lower cardiovascular events in these patients and intermediate syntax score. Of course, we have to take into account the diffuse disease on the daughter's branches. So they did it in 214 patients, and we can see that in the results, the PCI went better, and that deferring the treatment of these patients, it was not increasing the number of patients that need a second revascularization. It's important also to remember that sometimes we have not sometimes that so far at this point, we have not really have a cutting point that will be as, let's see, as clear with the FFR, joining the IFR or other index, because we have seen that sometimes the discrepancy can arrive to 19–20% of the cases when we measure first EFR and then FFR. And also that sometimes if we make the decision based only on one of these index, or the FFR or the physiological resting index, there might be a reclassification of this lesion into a 44% of the lesions. So it's very important. We also have to take into account in the left main whether or not we have the right coronary artery occluded. And we have also to find out and remember that the FFR and this physiological index will be influenced by the available or the viable myocardium that we have. So there's no point. We have so far the recommendation is to still perform FFR, and if we want to perform the EFR, it has to be done additionally to intracoronary image to assess the severity of the left main. Once we're treated, we have this, whether or not we should do a more complex technique. I'm not going to refer to the technique itself, but if we use a one stent approach and we left jail the circumflex, we can find that at 5 years outcome, according to this FFR as a guide to whether or not decide to treat or to do a more extensive technique over the circumflex. When we use the left main crossover stenting, we can find a more accurate and precise way to select whether or not to intervene in these patients. So it's important also to consider the extent of the circumflex of when we treat these patients, and remember that if we have an occlusion of these branches, we're going to have a significant clinical event. We have to consider when we do the physiology of these patients, the downstream stenosis in both branches that can arrive to a 30 or 40% of the cases. And when we do that, after treating, we have to use very careful technique as whether to use the wire pressure to avoid putting the catheter to cannulating too deeply into the main left main, or we have ostial disease left in the remaining in the left main, or we have strict protruding, and we have to be very have many options as to use different indexes, as to use FFR in a way to establish the physiological success of this revascularization. What we can do wrong, we have always to remember that if we have the wire path and we want to evaluate the result after planting a stent, we can measure the physiological index of the FFR, but then we have to retrieve the wire and see that we were rightly equalized and we don't have any drift, or at least a drift less than 0.001, as to really have the accurate and the precise result of our intervention in terms of physiology. So coming back to this algorithm, what we need to do is first, is it a bifurcation we're treating and it's clinically important? It is important in the way of ischemia burden, patient symptoms, or arrhythmias, genesis? Yes. Are we going to treat it? Then we have to evaluate physiologically both main and secondary branches, and then according to the physiology and the precise anatomy and the results of the image, then decide what kind of technique we're going to use. And in terms of using one technique, one stent technique, we have always to evaluate the result of the side branch physiologically, not imaging, because it can seem a better, even only, of course, in cases where we have a telemetry flow and the patient is not symptomatic, even if the lesion seems too tight, we have to measure it with a pressure wire before deciding a more complex or a technique or a different approach. What's the future of this? We're going to have this physiology index through a non-invasive test as a CT, and it's going to be able to predict, not to predict, but to guide the kind of treatment that we're going to do based on the physiology of each branch. So we have to remember that bifurcations are complex. Physiological approach must be important and part of our everyday practice when dealing with a bifurcation lesion. Can reduce and will reduce the amount of techniques and procedures done in this bifurcation that in the long term will reflect on less MACE. And the new techniques that are going to be not invasive will help us to plan in advance what kind of technique in terms of physiology we're going to use to treat that patient and to improve symptoms, ischemia burden, and in the left main bifurcation, prognosis. So that's all for this small talk. I hope it was interesting for you, and I'm open to any kind of questions that you have.
Okay, so yeah, thanks, Dr. Merida, for your nice talk. In interest of time, maybe we save the Q&A session to the after the next talk. So I'm Dr. Frankie TAM. It's my great pleasure to introduce a speaker from another continent, which is the Middle East. So she's Dr. Mirvat ALASNAG. I believe she's from Jeddah, Saudi Arabia. And her talk, the title is about intracoronary imaging in bifurcation lesion. How imaging guides our PCI strategy. Mirvat, please.
Well, thank you for having me, and great topics today. So I'm going to be discussing the role of imaging to guide PCI, and really before the PCI itself. Interestingly, when I was preparing for the talk, I wanted to look at data on this subject, and I wanted to see if there was enough data on it. And yes, there is. There's plenty of data, as a matter of fact, on the role of randomized trials on the role of OCT alone, or IVUS and OCT compared with PCI. There's also a very elegant joint consensus document of the OCT and coronary bifurcations elaborated by the European and Japanese bifurcation clubs and published in Eurointervention 2019 that I urge you to have a look at. There are several trials that are ongoing, the IMPROVE trial, Illumian, and October. And October really is the first that is adequately powered clinical trial that demonstrates routine use of OCT to guide stenting does actually improve outcomes. And this was a really elegant trial that looked at patients who were obviously over the age of 18 with stable disease. They also included stable acute coronary syndromes, i.e. stable non-STEMIs, and they excluded STEMIs, cardiogenic shock, low EF, and so on. And they looked at angiographic criteria for these patients. They wanted native or de novo lesions, more than 50% stenosis of the main vessel as well as the side branch. And then they randomized them 1-to-1 OCT guided versus standard or angiographic guidance with possible IVUS evaluation. And then they looked at 30 days, 1 year, 3 years, and will continue to look at a combined endpoint of major adverse cardiovascular events. It's a superiority trial, really that's the design, and they're looking at cardiac death, target lesion, myocardial infarction, and ischemia-driven revascularization. So my role today in this talk is really to do the first box, and then some of the colleagues will continue to look at the role of OCT subsequently during the stenting procedure. And really what we want to do is look at pre-dilatation, looking at the stenting and the landing zones, looking at reference sizes, and ensuring that the length is okay. And I'm going to just touch on this a little bit more in a few minutes. But let's look at this case. This is a standard case that we actually did in our own lab. This is a patient who had a long LED disease. It was FFR was significant. And we all do see that there is disease in the diagonal branch, which is a sizable diagonal branch. But when we eyeball it, and we want to keep things simple, we want to be provisional. You know, we're looking at the ostium of the branch, the side branch or the diagonal, hoping that we can get away with a provisional single stent strategy. Of course, we do have to look at the angle of the main vessel in the side branch. We do have to look at the length of the lesion in the main vessel, ensuring that we have adequate place for proximal optimization. And then, of course, the length of the lesion that is in the diagonal branch. And so we went about doing our PCI, and you can see we've stented the main vessel. We have a wire in the diagonal branch, but you can already see here that the flow in the diagonal is significantly compromised. And so we did have to go with a bailout technique where we ended up, because we did a good pot, we were able to recross into the diagonal branch and then do kissing inflations, position a stent. So this is basically a bailout tap, and then do kissing inflations in a final pot. And this is what we ended up with in this patient, both in areocranial and iliacaudal. But in 2023, what we do want to be considering is how can we evaluate bifurcation lesions more accurately? How can we decide on lesion preparation, the size of the stent, the landing zones, and actually how can we predict side branch compromise? Was this predictable? Was this preventable? And could we have gone with an upfront two-stent strategy? Apologies, this is my iPad is on. So this is an algorithm that I'm sure you've seen a lot. It's available for OCT, but it's also available for IVUS. What you do see is this. This is what I'm going to focus on in my talk, MLD. So the morphology, the length, and the diameter of the vessel before we decide on stenting. It is fairly classical. I'm going to start backwards. So I'm going to start with the D. So we're looking at the diameter. There are really two ways to look at it, either a luminal approach or an EEL approach. And if you can define the EEL well, then most of the time you will end up downsizing slightly for it. And then looking at appropriate landing zones. So most of our patients, particularly diabetic patients, particularly patients with multivessel disease, they're not going to be completely normal. Ideally, yes, you do want to park your stent, whether in the proximal reference or the distal reference, in a completely normal segment, but that's sometimes ideal and not always what we find. So you could look at a fiber segment, a calcified segment, but perhaps the worst is finding a segment that is lipidic and suggestive of ongoing inflammation and so on. And so what we do want is prevent future events. We want to prevent future restenosis and so on by selecting the most appropriate landing zone. And then moving backwards, we move to the morphology. So we want to look at the morphology not only of the main vessel. So even if we're opting for a primarily provisional strategy, or a default provisional strategy in a particular patient, we still have to understand what's happening in the side branch. So the morphology is their calcium, for example. So we have to have an understanding of whether it's superficial, deep, or nodular, and whether this kind of calcification is eccentric or concentric. But then, there are different types of algorithms that you see for OCT, and you see them as well for IVUS. But importantly is to not only look at the depth or the thickness of the calcium, but to look at the arc of the calcium and how superficial it is. And the same thing, there's this that was already published in Circulation on IVUS. Again, looking at the arc of the calcium, looking at the depth of the calcium, and coming up with an algorithm on whether or not you should be really using some kind of atherectomy. Now, when we talk about this OCT versus IVUS, I don't think the scope of my talk is to go over OCT versus IVUS. What I would say at this point in time is get comfortable with the device that is available to you in your lab, get comfortable with the interpretation. This is the same patient. You do see nodular calcium, and you do see a significant arc of calcium both by IVUS and OCT, and you see it again over here. Now, if you're got enough experience with interpretation of both, then so be it. But if not, I would say get comfortable with one or the other. and interpret the side branch as well as the main vessel. Why do you need to do that? Because you need to decide on what your next step is. If your side branch is involved, are you going to keep a wire there and opt for something like shockwave? So I know we talk about the calcium depth and the degree of calcium and so on when we decide on atherectomy. But perhaps we need to be factoring in the side branch, how significant the disease is in the side branch, and the likelihood of losing it as well. So when you have rotablator, you don't maintain a wire as opposed to, for example, shockwave. And so these are all considerations. I don't think we really have the data for it or the evidence. We do have some experience with it, but it certainly is worthwhile. And moving on, so whether we're talking about stable disease patients or unstable disease patients, so patients who have ruptured plaques and so on, we do need to evaluate the ruptured plaque itself and what happens in the side branch relative to it. And believe it or not, when I go back and talk about experience, I have seen examples of this where an ulcer is misrepresented as a side branch. So it is critical that we understand how to interpret these images and not just go through the maneuvering and do them, because it certainly does make a difference. This is a really elegant publication by Holman Group in neurointervention that actually looked specifically at OCT, bifurcation, stenting, and what we really have learned. So we do want to look at the main vessel, both the proximal segment and the distal segment, but we do want to look at the bifurcation. We do want to see the disease and the significance of the disease opposite the side branch, and then of course how much of it is protruding into the side branch itself. And based on that, maybe we're going to change the Medina classification. So, if initially we didn't think the side branch was involved or the distal vessel was involved, maybe now we know differently once we pass an imaging catheter and we see now more plaque protruding. And perhaps once we redefine the Medina classification, we redetermine whether we want to be doing a TAP or Culotta DK crush, i.e. upfront two-stent strategy versus a more provisional strategy, looking at all these criteria. But the definition 2 actually told us what to look at in the side branch in terms of size as well, in terms of angulation, length of lesion, and so on. And perhaps eyeballing again is not enough. So going back to the same publication where you do want to be looking at the side branch and how you can assess it. So there's several mechanisms to do it. The simple and sort of quick and dirty way to do it is panel A, where you just trace the side branch in a cross section at the level of the carina and get one for the main vessel as well as the side branch. Otherwise, you can do it in a more longitudinal frame where you look at the side branch ostium and you calculate the area. I think it's a bit tedious and some of us don't want to go through that exercise, but perhaps it is worthwhile for significant side branches such as the left main vessel. And then, of course, there's counting the numbers of cross sections where the side branch is visible, and then you look at the thickness, and again, you calculate it, or you measure the width of the side branch on 2D and 3D and determine the length as well as the size. I think this is a little more crude. Personally, I'm not very efficient with it, but trying to build my experience. And then again, looking at this particular example, a little similar to the one I showed you, but maybe a little more obvious, where the patient showed a Medina 0111 lesion in the LAD in the diagonal, and there was an eccentric plaque located opposite the side branch. So you do see in panel B opposite the side branch. So you do want to be able to measure at this point in time the diameter of the side branch orifice, and you do want to see the length so you can determine your landing zones. So if you look at over here, you're looking at the angle of the bifurcation, and the angle of the side branch itself where it comes off. So as we're doing all of this, as we're trying to determine the side branch itself, where it comes off, what angle it comes off from, and where we're trying to determine a safe and healthy landing zone, we also want a landing zone that's going to give us enough room to do the proximal optimization. And so, in one frame, there are multiple things that we need to be looking at. And I think getting both a longitudinal and a short axis image is perhaps the wisest to do, and to spend a little bit of time doing it. Make sure your patient's ACT is okay, step away from the wires and the catheters, look at your console and look at that segment and evaluate it appropriately. So look at the proximal segment, determine where there's a safe landing zone, you're not looking at lipidic segments and so on. look at the length and where you can have enough room for proximal optimization, determine the reference diameters proximally and distally, but then look at your side branch. And with your side branch, you are looking at morphology. You are looking to see if there's plaque extension into the side branch. You're looking at the angle of the side branch itself, and then you're looking at the segment contra on the contra side of the side branch to see if the likelihood of plaque shift is going to happen, even if the side branch itself did not have significant disease initially. And again, this is showing you that you can do cut planes, you can do 2D cross-sectional segments, and you can do very longitudinal reconstructions that many of us are now experimenting with or learning how to do. And ideally, you want to be looking at all the points that I was mentioning. So you do want to be looking at the side branch angle as well as the carina tip angle, and be able to determine whether your chances of having shift is higher, as in the case that I did show you. The next thing that you do want to see is where your wires are. Now, intracoronary imaging can be very helpful in showing you the two wires relative to each other. If you've already implanted your first stent, again, that may help you to determine where your wire is and where you're recrossing. Again, I'm sure this will be touched upon by my colleagues as they move on to the other parts of imaging during PCI of a bifurcation. But the only reason I also bring it up is so we remember that some of our patients that come back are not de novo lesions. So they're not all falling in the trial that I just showed you. Some of them may be coming back with in-stent restenosis at a site of a bifurcation. So it is critical that we understand and use all the tools that are available to us. So whether we're looking at only stent display or lumen display, whether we're looking at fly-through, and so on, to evaluate it, but also to see appropriate apposition, expansion of the stents in those segments where you do have maybe in-stent restenosis, neoatherosclerosis, see whether you need to do more expansion, and to see where you need to be crossing safely into that side branch to protect it and to manage it, whether you do need now a second stent there or not. I think I'm going to stop here and just kind of turn it over to a discussion, because I'll be spilling into the next talk, I suppose, if I continue.
Mirvat, thank you. That was a fantastic presentation, and really the combination of your and Merida's opening presentations offers a huge amount to think about, and if anything makes bifurcation seem even harder. So there's a question that's already been raised by the audience about which technology would you choose, and I think that's a pretty tough question. But I guess if I could spin that round, do you think there's a role that we should be applying both physiology and imaging to achieve optimal results for our patients? Turn that to you firstly, Mirvat, and then ask Merida her opinion.
Yeah,
so
I think
for
there's
me,
Sorry, go ahead.
Yeah, for me, physiology, I usually start with it to kind of determine the importance of the lesion that I'm seeing, especially the side branch and so on. I tend to rely a lot more on imaging to optimize the PCI and to kind of determine the strategy for the PCI itself. So if I'm talking whether I want to do the PCI or not, whether it needs the side branch is significant or not, probably physiology. But to determine the strategy and the optimization, it's usually the imaging.
So in an ideal world, we'd use both, but the reality for most is they don't have the money necessarily to justify the use. So Merida, you touched upon in your presentation the use of not either non-invasive technologies or reconstructing through angio or OFR type reconstructions. Is that going to be the future? Do we use imaging and get physiological measurements taken from both the angio and the imaging rather than using an invasive wire?
I think it's going to be the future, and it's going to be an easier way to prepare and to plan our angioplasty. I think that after, the image will be useful to really evaluate the good result of the technique. But we have to take into the account first, despite the image, that we are dealing with physiology. This is not a beauty salon to have a perfect bifurcation. It is functional. It is the patient, and it's regarding the burden of ischemia before. So I think, yes, it's going to be a way to, before taking it to the cath lab, to really plan our our technique.
Okay. Now, if we're talking about beauty salon, then Mirvat, the information that strikes me most from your presentation is nodular calcium. It's a real pleasure to have Akiko with us on the panel today, and you've obviously outlined the 5-5-5 rule. But if we go beyond quantifying calcium, I'd be really interested to know where Akiko stands in terms of the beauty salon. How do we deal with the nodular calcium, the qualitative assessment in that morphology element of the MLD? How should we be altering our intervention dependent on the beauty of the calcium?
So in
horror
terms of
the calcium?
Yeah, I think the calcified nodule, we have to differentiate two different types. One is we call the eruptive, which meaning the surface of the calcified nodule is more likely irregular. And non-eruptive is you have the nice, smooth, fibrous cap on top. And eruptive more likely can be deformed, even balloon, but nodular is very difficult. So I think if you see the eruptive type at the bifurcation, that can be benign, but if you have the non-eruptive, it's more likely harmful for the collider shift after the stenting. So not only the nodular presence of the nodular calcification, but also what type of the nodular there, that's actually important.
Okay. You say benign, you mean benign in the sense of how it's going to behave interventionally, but it's potentially quite malignant in the way that it's presented. Right?
Yeah. Thank you so much. I mean, benign meaning at the acute phase, get a good expansion. But I think it's important to understand the long-term outcome. Actually, eruptive is more worse outcome because they are reprotruding through the stent. So I think we have a lot of learn to deal with these things. We don't know yet, but probably some sort of the debulking before stenting for those type of the issue, we have to really look into more.
Okay. Well, that may well be a beautiful segue through to our next presentation, which is from Frankie TAM, friend and colleague in Hong Kong. We're conscious of the fact that this is likely to overrun in terms of the 2-hour symposium with such an ambitious program. Really want questions from the audience, and we'll engage the panel in further discussion through. But for the purpose of time, we'll move to Frankie's live case, and hopefully we'll expand on some of the things that we've already seen through the presentation so far. Frankie.
Yeah, thanks, Thomas, for your introduction. So thanks for inviting me to be here to this very nice symposium. So now I would like to show you a case of a recorded live case of using actually OCT for left main bifurcation lesion. All right, just before I forget, so this is a little bit advertisement. So I think this TCIP, we have a live conference in Hong Kong, live in November this year. So everyone will be welcome to join this. Okay, so let's go to the case. So this is a 74-year-old man, hypertension, ex-smoker. He actually has history of PCI to the so-called osteo-LAD and osteosurgery and RCA more than 15 years ago. Obviously, we don't have details of all the images of the PCI at that time. And this time, he actually admitted for chest pain, angina, and actually non-STEMI. His condition is stable, but the echocardiogram actually shows a globally impaired LVEF of around 30%. And the MRI heart actually shows viable myocardium. The coronary angiogram, which I will show you in the moments later, show actually distal left main and triple vessel disease and very calcified vessels. So these are the angiograms of this patient. You can see actually the stent looks okay, but we can see the stent in it, right? The severe stenosis in the distal left main, osteocircumflex, and the osteo-LAD. And also some disease diffuse ISR in the mid-LAD, also the diagonal and distal circumflex. But the bad thing about this is we don't know exactly what's the relationship between the previous stent to the left main. We don't know whether there's any stents protruded into the left main or any stents just protruded from the LAD to the cert. We don't know. This is the RCA. Again, we show very tight ISR in the mid-RCA region. So this case was discussed in our heart team meeting. However, the patient strongly refused CABG. So we don't have other options. We proceed for the PCI for this patient. To make this safer, actually we first perform the PCI to RCA first with IFS guided. And these are the final results. And now we have to go to the PCI for the left system. So concerning this patient, is elderly patient with poor LVEF and a distal left wing bifurcation lesion with properly calcified lesion, we anticipate we will use some sort of atherectomy. And again, this is possibly the ISR with unclear anatomy of the previous LAD and third stents. All right, now I will share the video. Okay, can you guys see my video? Okay, so this is a so this case we performed using an impeller assisted PCR of the left distal left wing bifurcations. So just now you can see the caudal wheel now is the cranial wheel. So this is a 7 French guiding catheter XP LAD 3.5. Again, you can see some diffuse stenosis in the distal LAD, but I think the main culprit is still the distal left wing bifurcation. So in this case, imaging is very important to tackle this case. So we first want to do OCT for both the LAD left wing and the circumflex left wing. So this is the OCT from the LAD to the left wing. This LAD OCT is very important because first we know exactly what's the relationship between the previous stents to the distal left wing bifurcation, and also we exactly know how severe it is, and also the plaque characteristic of the left wing. So you can see this is distal left wing. We can see this is so-called a smooth calcified nodule with concentric calcium of the distal left wing stenosis here. Actually, the osteo-LAD stent did not extend to the left wing. So we can see the calcified nodule at the distal left wing and the concentric calcium. And then we perform the OCT from the circumflex to the left wing. So this is the angiogram, and this is the OCT. So we can see actually the third stent is quite okay from the OCT. But what we want to be sure is actually the stent inlet of the circumflex stent and its relationship to the distal left wing and whether it is protruded to the osteo-LAD. So you can see this actually the osteo-circumflex quite tight stenosis with the thick calcified plaque just opposite to the carina. So this is the typical plaque characteristic of all bifurcation. That is, the flow divider have the most heaviest plaque burden. And in this case, the worst thing is this is a very calcified plaque in the osteo-circumflex just opposite to the carina, opposite to the LAD ostium. Again, in the left wing is quite okay. So because of the calcified nodule in the left wing and also the LAD, we did some atherectomy. So we used the 1.75 burr first from the left wing to the LAD. So in burring like this, we try to keep slow and try to be careful, because if we don't be careful, we may destroy the LAD stent. So we first start at 180 RPM, and then we try to increase our ablation efficacy by lowering our RPM to 160 RPM. So we go in slowly with cruising maneuver, try to get as much the debulking strategy as much as possible. Besides the speed bias, we also try to adjust our guiding catheter to achieve a better wire bias, again, to try to achieve a better ablation efficacy by adjusting the wire bias by the guiding catheter position. So we deep sit our guiding to make the guiding point a little bit upward, and then we do the ablation again. So after the 1.75 ablation, we do OCT again to see whether our ablation efficacy is good or not. So this is the OCT after the 1.75 ablation. Actually, on the angiogram, you can see we are doing quite well. And you can see this is the very nice ablation we created in the distal left wing and the osteo-LAD. We bite some chunk of calcium, especially at the calcified nodule in the distal left wing. But however, you can still see quite thick calcium around various positions, which we might have to do more after the root ablation. After we finish the root ablation to the LAD, we then turn our attention to the root ablation to the circumflex, because we see the calcified plaque at the flow divider of the osteo-circumflex. So 1.75 burr from left wing to circumflex, but this time it's not that easy because of the sharp bend, sharp 90-degree turn to the circumflex is actually not very easy to get the burr across. But especially for fellows, so in doing this root ablation across this deep angle, we cannot just use blunt force. If we just use blunt force to push, the whole system will back out. So we really have to go in slowly. Also, we can try to adjust various bias. For example, we try to increase the speed, to adjust the speed bias to see whether the bird actually get across the osteo circumflex. However, in this case, the 1.75 bird just cannot cross. So if we cannot cross, what we can do? We can step down the bird, we can use different guiding. But in this case, we use imaging to assess why the bird does not cross the osteo circumflex. So another tips and tricks here, you can see that actually the OCT catheter this time cannot cross the osteo circumflex because of the wire bias here. Again, if we just use blunt force to push, the OCT catheter will just like this, will back out and prolapse in the LAD, which will trap the OCT catheter. So in this case, we use the buddy wire technique here. We get another wire. Because of the wire bias of the buddy wire, the OCT catheter just cross with some manipulation here. So after the OCT cross the osteo circumflex, we pull the OCT to assess the reason why our bird cannot cross the osteo circumflex. All right, this is the OCT pullback. You can see the tight stenosis in the osteo circumflex. And this actually shows you exactly what happened here. So this OCT catheter, and this is the workhorse wire. And actually, we can see the water wire is actually around here, right? And we can see the water wire just touching the calcified nodule. So the reason why the bird cannot cross the osteo circumflex is because of the calcified nodule. And I can tell you that the wire bias in this case is actually excellent for the motor patient to work. So in this case, it gives us more confidence to try to step down our burr and use a little bit more force to push the burr around the corner to ablate that calcified nodule here. All right, so this time we step down our burr to 1.5, 190K RPM. So in this case, we have to be patient, use a little bit more force, and bit by bit to see whether the burr can get over the calcified nodule around here, just like this, all right? So in this case, the 1.5 burr can get across the calcified nodule. And of course, after this, we do a few more runs, particularly to reduce the speed down to achieve, again, more ablation efficacy. Like this, all right? So after the mode ablation, again, we do an OCT to see how well our water breather works. So this OCT after the 1.5 burr mode ablation. So you can see this OCT again show very beautifully how the mode ablation work to this osteo circumflex lesion here. So now this is a proximal cert. Now we're going to the ostium. We can see our mode ablation burr actually have a very good ablation efficacy of the osteo circumflex calcified nodule just opposite to the carina. So in this case, this mode ablation really did a very good job to ablate the calcified nodule at that area. So I think we are doing good enough for the ablation. Then we want to do a short wave to the left main LAD because we can still see thick calcium at the distal left main. This is a 3.5 by 12 shockwave balloon. So for those who are not familiar with shockwave balloon, so we inflate the balloon, we press the button for 10 seconds, and the shockwave deliver to try to crack the calcium. You can see the shockwave balloon expansion is quite well here. So after the shockwave, a few cycles of shockwave, we want to again perform another rounds of imaging to see whether the shockwave is good enough, or we need another round of preparation before putting a stent. So this OCT on the angiogram, you can already see quite good actually the lumen gain after the shockwave and the mode ablation on both sides. All right, this is the OCT. You will see in a few seconds time. Right, this is the OCT. You can see beautiful cracks created. This is osteo circumflex. Beautiful cracks created at the distal left main. You will see. So beautiful cracks here at the distal left main, and also some cracks around the calcified thick calcified part here and here, and also some more. And also the lumen gain is quite okay, I would say. So after the OCT, we think the preparation of shockwave and nephrectomy is enough. And then we use some high pressure ballooning for both the LAD and also circumflex. Okay, so this is the osteocircumflex, NC score flex, the high pressure ballooning. So after the high pressure ballooning, now we have to decide what with the standing strategy of the distal left bifurcation. Should we do another 2 stand here? But mind you, there's already 2 stand in here already. If you put 2 more stand, then there will be a lot of stand around here, which I don't think is good for the patient. So in this case, we adopt a hybrid approach. We use both the DCB and the DES approach to this area, this left bifurcation. So we just do the DCB to the left main or to the osteocert. So this is DCB to the circumflex area, right? The expansion is quite okay. And then after the DCB to the osteocircumflex, we do a left main LAD DES from the ostium. So this is a hybrid DES DCB strategy. Well, of course, after this, we will do port, kidney inflation, and then we will do the evaluation again. All right, this is the port, high pressure balloon again. Right, and then we will do a high pressure sequential ballooning of the osteoid and the osteocircumflex. This is the high pressure ballooning as the osteocert. And then the LAD, and then we will do a kissing balloon inflation. Right, afterwards we will do a OCT to assess our post-stenting results. So this is the OCT from the left main to the LAD. So we can see actually from longitudinal view, we already have a quite good stent expansion. You can see the MSA is quite okay. And you can see in the left main again, the stent is quite round with some mild malposition and some contrast artifacts in the osteo left main. So in this case, I think the LAD is quite okay. This is in the OCT, the circumflex to the left main. This we want to evaluate the osteocircumflex stent expansion and MSA. All right, so you can see actually this is not perfect, but we'll say it's acceptable. Again, we can also see some stent malposition in the proximal left main, which we do a little bit pot to optimize it later on, like here. All right, so this is the final result of the angiogram. This is the aerial cranial wheel. You see good stent expansion in the left main and the proximal LAD. For the distal LAD, we decided to treat it medically without putting it in another stent. So this is the AB cranial wheel. Again, quite good stent result of the left main area. All right, this is the caudal wheel. Right, I think it's not perfect, but I think we are. I would say from the OCT, the stent expansion is quite optimal for the left main, osteo and osteocircumflex. So I think that's the end of my case. So any comments from panelists or anything we be doing differently?
Thanks, Frankie. That was a great complex case, definitely. Impella was in, Rota, Shockwave, OCT. Dr. Pham has his hand raised, so I'll give him the first go at asking a question.
Thanks, Chee. Thanks, Dr. Tang, for that excellent presentation. I'm just wondering, your OCT pictures are excellent. Wondering whether you can share some tips and tricks on how to achieve a good clearance of the contrast when you do left main stenting.
Yeah, that's a very practical question. So I think for doing OCT is possible in left main, right? Just to make sure that we have a good contrast clearance. So in this case, I think the key is actually this is a 7 French guiding, so it would be easier to get a good image. The second thing is to get the guiding coaxial, right? If you get the guiding coaxial, you will get a very good OCT image. But sometimes the left main is too big, all right? For example, a 5.0 or 5.5 left main, it may still be difficult, but again, choosing a bigger guiding and so a more coaxial position will be giving a very good OCT appearance.
Dr. Lucio Padilla, you have a comment?
Yes, very nice case, Frankie. And the thing is, what about the instant restenosis in an ostial lesion? And what about DCB after this very nice optimizing of the plaque? So what my idea is when to use DCB, and my idea is after we do a very good plaque preparation, just is to say with RotaPro, with IBL, with OCT guided, go with no compliant balloon, the bigger one regarding with the size that OCT shows to us, and after a very good preparation about the size of the instant restenosis, do the DCB. Not use DCB if you have a infrastent lesion or not a good expanded stent, or a residual lesion more than 30%, or a dissection of Timoth 3 less than that. So nice case to do DCB and very good result. Congrats.
Yeah, thanks, Lucio. That's a great comment.
Okay, James.
Oh, yes. Thank you. Thanks, Frankie. This is a very challenging case. Excellent outcome. I was just wondering, going back to the first presentation on physiology, I might have missed the MLA on the pre-intervention OCT pullback, but the MLD does look like it was 2 millimeters pre-intervention, so probably a small MLA. But when would you consider performing physiology in these type of left main situations, considering some of the pitfalls for physiology in these situations? And perhaps even after the intervention, would you do a post-PCI physiology to confirm that you've actually revascularized the left main?
Yeah, so that's a great question. So Marida's great talk. I mean, they're using the physiology and imaging. Of course, it's ideal in theoretical situation, but in real life, I may not be doing both of them in all my cases. So in this case, because I think the ostial shirt is very tight, right? So I think it is a big shirt. So I think even I don't do an physiology, I think the ostial shirt is already deserves some sort of treatment. And for the LAD, although it's not the tightest LAD, you see, because of distal left main stenosis and also the calcified plaque, and also since we want to do something with the circumflex, then I think I will do the left main LAD. I will do something to the left main LAD. So in this case, I don't want to do a physiology to start before this case. So just to make sure that I'm not confused after I do FFR or IFR to both the branches here. But that's a great comment, yes.
Thanks.
And we'll take one last comment or question from Akiko before we move on.
Yeah, I'm sorry. I have the question. In terms of the usage of the shockwave on top of the low tabulator, meaning you mentioned the wire bias is really good place. That's in just comment how you're using the wire bias to predict the low tabulator effect. That's number one. And the second question was, when you use shockwave on top of the low tabulator, this case, I thought the calcium is really a lot, but not truly concentric, not circumferential. So if we do this case at Columbia, probably we do LOTA, but maybe we just go ahead to balloon instead of the shockwave. So those two questions.
Yes, thank Dr. Akiko for this great question, right? So the first question, how do you predict the wire bias? Probably you will know more. You will know more than I am, right? Because the rotor always go with the rotor wire, right? So all the imaging, be it IVUS or OCT, if the wire and the imaging catheter are parallel, if this touching the plug, we will know actually this is actually where the burr will go, right? This is how we use imaging to guide our rotor ablation, right? So in this case, the wire is actually quite in a good position, whether it's in the LAD or in the circumflex. So we know that the ablation of the burr will be in a great place. Sometimes if this is not the case, we may adjust our rotor wire. For example, we use a stiff wire, or we may adjust our guiding position to see whether the bias is in a more favorable position for us to do the ablation. For the second question is, I agree with you that this is not the most effective calcium appearance for shockwave to work. The best would be the concentric thick type of calcium. The shockwave will work very beautifully with different cracks go across the calcium plug, right? This is not the best picture, right? But I would say that because after the rotor ablation on the OCT, we still see quite thick calcified plug, right? We know that shockwave may not work best in eccentric calcium or not concentric calcium, but I think shockwave can still work in, for example, not 360 concentric calcium. Just that we have to do more pulse, more cycle. So in this case, because of the thick calcium, we still opt to do shockwave. In this case, we use that 3.5 shockwave. We do all the 80 pulses to that distal level in the LAD area. Hope that we can achieve some cracks there. So that's the reason why we want to use that.
That's great. So I think we better move on. I think it was a great case and great demonstration of imaging in a left main bifurcation case. So give me a sec. Our next speaker is Dr. Lee Zhen-Vin from Malaysia, and he's going to speak to us on how to use intravascular imaging to assess the results and complications of bifurcation PCI. Please, Zhen-Vin.
Well, thank you very much, Dr. Chen. Hello, everyone. As always, it is a pleasure to connect. So I have been tasked over the next 12 minutes or so actually to speak about the usage of intravascular imaging to assess the results and the complications of bifurcation PCI. So Dr. Mirvat has actually covered the MLD part of the MLD Max protocol. So I would actually be doing the Max component of the MLD Max protocol. And without further ado, I wish to now proceed. I think I would go as far as to state that in contemporary practice of bifurcation PCI or complex PCI as a whole, the routine use of intracoronary imaging is extremely important. I think the overall evidence is compelling. We have data from a Korean registry amounting to 6,000 patients to suggest that the utility of intravascular ultrasound had actually reduced the cumulative incidence of cardiac death in a group of patients with complex PCIs being done. And as you can see over here, bifurcation lesion was one of the subset or subgroup of these procedures. And of course, this is also extremely relevant and is more so more important for patients to also undergo the procedure with a systematic protocol of predilation, stent sizing, as well as post-dilation. And these are results from the IRIS DES registry. And you can clearly note that the primary outcome, which was a composite of cardiac death, target vessel MI, or target vessel revas, was significantly reduced when the IVUS was used versus purely a coronary angiogram guided sort of a PCI. Of course, with regard to the subset of patients for our discussion today, which would be coronary bifurcation PCI, there are also numerous studies that have clearly demonstrated the fact that the utility of imaging is clearly better and superior as compared to the utility of just an angiogram alone. And I am conscious of the fact that there is actually a talk by Dr. Pham right after myself with regard to the comparison between OCT and IVUS. But the reason I'm showing this particular slide is just to show that with regard to the performance of bifurcation PCI with imaging guidance, the OCT is in fact better in a number of factors or a number of reasons compared to the IVUS. As you can see on screen, it gives us better control of wire recrossing. It allows us to better assess standard position, the assessment of lesion coverage, as well as it gives us a better assessment of thrombus, plaque protrusion, as well as age dissection. And this is the reason why a lot of my subsequent slides would all be with the OCT rather than the IVUS. I think prevention is most definitely better than cure. It's always important to identify predictors of side branch compromise as opposed to salvaging a side branch compromise later on. Dr. Mirvat has touched upon this, but I think it's important to re-emphasize that these are the predictors that would serve as guidance as to what sort of a bifurcation PCI that we are dealing with. The carina tip angle, branching point to carina tip length, bifurcation angle, pre-PCI side branch degree, stenosis, calcified plaque in the main vessel, as well as the importance of the presence of lipid-rich plaque contralateral to side branch ostium. So all of these things would serve as important predictors to guide our intervention strategy. So if one were to look at the overall algorithm, I think this has been extensively covered by Dr. Frankie as well in his case demonstration, but I just wish to reiterate the fact that when one utilizes the OCT, it gives us the added advantage of having the information known to us, which would be the standing location as to whether the stand is carina link-free or not link-free, and it also guides us with regard to the guide wire recrossing point. It also allows us to identify whether there are presence of jailing struts at the ostium of the side branch. If one looks at the algorithm for IVUS guided PCI, of course, we are able to then assess the plaque burden prior to the PCI itself, and it doesn't actually allow us to guide distal wire recrossing, and which is why when one assesses the algorithm for the OCT, it allows us to, in addition, obtain information with regard to all that we have spoken about. It allows us to also assess for the presence of plaque erosion, thick firm macrophage accumulation, and more importantly, it allows us to guide our guide wire recross by providing us with substantial information by means of the 3D OCT that you would see later on. I think this is something that you have seen very often in many of the previous presentations, but suffice to mention that these are the targets that one should actually try and achieve after the PCI itself by means of the utility of imaging, whether it's IVUS or the OCT. Some of the algorithms or some of the targets are inherent to or localized towards one particular method of imaging, but generally these are the targets that one should try and aim for after the performance of the PCI itself. I will now go on to show you some illustrations from the literature as to what are some of these complications to look out for after the procedure itself by means of the utility of imaging. With regard to the OCT, one can actually use the OCT to assess for malposition as to whether the stents would require additional ballooning with a semi-compliant balloon or not. It allows us to look out for significant dissections as well as significant plaque prolapse, which may require some intervention after the utility of imaging itself. This was what I was alluding to with regard to side branch predictors of assessment of the carina tip angle as well as the carina tip to the branching point length. And here you're able to note that this is a link-free carina after the procedure itself, and the ostium of the left circumflex was not actually jailed or crowded with stent struts. And it's also important for us to know exactly what sort of a position that the stent strut occupies with regard to the ostium of the side branch to guide recrossing of the guide wire should there is a need to actually intervene with regard to additional stent strategy, additional stenting procedure, or the performance of a kissing balloon inflation. There is a theoretical risk, and this has been published in the literature, of the formation of fenestrated wrist stenosis if the struts are occupying the ostium of the side branch, and this lesion was deemed to be physiologically significant. And in the worst case scenario, this can also lead to a complete endothelialization of the ostium of the side branch, and this can actually be rather catastrophic as per seen from this particular case that was published in the literature. Of course, at the end of the procedure, by the utility of 3D OCT, we all hope to get this sort of an image, and I think that amongst the many options that we have with regard to the utility of OCT, the 3D OCT feature is one that I fancy the most. Ideally, the dumbbell sign should actually be obtained, along with the fact that there should not be any form of edge dissections seen after the procedure. I think with regard to the assessment of complications, well, although in-stent wrist stenosis is not only limited to bifurcation PCIs, they can also be present in non-bifurcation PCIs. But should these be present in bifurcation PCIs, I think OCT also provides a superior ability for the assessment of in-stent wrist stenosis, as you are able to note on screen. And last but not least, in this particular case illustration from the literature, the operator had difficulty in advancing the balloon after rewiring the side branch, and from the OCT you can clearly see that the position of the wire is extremely eccentric, and this had clearly provided an explanation as to why the balloon could not be advanced down the side branch. So this was touched upon earlier by Dr. Mirvat with regard to a large outcomes trial, which is the October trial in assessing the superiority of OCT versus angiographic guidance PCI in a group of patients with bifurcation PCI. And I wish to state that if I were to be asked about what would actually be the strategy to mitigate complications from a bifurcation PCI, I think the protocol itself, as you can see, is extensive, but this should actually be made routine in clinical practice. In that at every step, I think the repeat performance of an OCT is important, especially after rewiring or after performance of any form of debulking strategy, as what you've seen from Dr. Frankie's case earlier on. With regard to post-stenting evaluation by the OCT, I think it's important for us to assess as to whether the lesion is fully covered to exclude any residual edge stenosis or major lipid plaques near the stent edge itself. Expansion deposition was something that I've spoken about early on. And it's also important to exclude accidental abdominal wiring. And the wire position is also important to be known. And I think that if one would actually employ such an algorithm that is systematic for the performance of every case of bifurcation PCI, then the overall risk of complications would actually be reduced drastically. So this would be some tips of acquisition, of OCT acquisition in bifurcation PCI. I think with regard to the main vessel pullback, one should, of course, evaluate if the side branch ostium is visible after the pullback itself, and sometimes it is, sometimes it is not. In the best interest of the patient, of course, irrespective of the strategy that one is embarking, even if it's a provisional single stent strategy, I think it's always important to assess the side branch as well with imaging wherever possible. In the case of conflicting wire shadow, I think it is important to consider manipulating the wires and repeating the pullback as well. Now, with regard to the side branch pullback, I think it's important to consider the risk of side branch dissection before wiring. And sometimes the wiring itself may actually lead to more complications. And if that's the case, one should try their level best to actually assess the ostium of the side branch using the main vessel pullback itself. One should, of course, avoid advancing an OCT wire into a jailed side branch. And one should also always ensure that the side branch pullback would actually extend into the main vessel itself, which gives you a complete assessment of the carina and not just the side branch alone. There was a question early on about left main. I think Dr. Frankie has demonstrated that it's extremely feasible to perform the OCT for left main lesions. And this was actually published in 2015. It was stated that aorto ostial evaluation is not quite possible, but we now know for a fact that with the utility of a telescope guiding catheter, aorto ostial lesions would also be possible to be assessed using the OCT. So I wish to finish up by showing you two cases of left main interventions using the OCT. The first patient, as you can see, had diffuse disease throughout the LAD that extends all the way into the left main. And I'm just going to show you the result of the procedure. So of course you can see the dumbbell sign being present. There really isn't any struts overlying the ostium of the side branch. And from the 3D view, this was really the ideal sort of result that one would actually aim for after the performance of a bifurcation PCI. But this is not always the case, as demonstrated by the second case, quite similar to the first one, diffuse disease in the LAD. I'm extending to the left main coronary artery. From this particular view, I think it's better appreciated. Post-procedure OCT, you can clearly see that the struts are actually overhanging and overlying the ostium of the left circumflex artery. And this is also better seen from this 3D OCT view. So at this particular moment in time, performed the FFR. This lesion was, of course, not functionally significant, but given all that I've spoken about with regard to the risk, I did actually perform kissing balloon inflation to finish up this procedure. So I think a point of discussion amongst the colleagues present today would be whether routine or rather kissing balloon inflation would actually be routinely performed after a provisional stenting. But I guess now with the utility of imaging, you have a better knowledge of what is exactly happening at the level of the carina, so it may or may not change your decision. I think as a summary, I wish to reiterate the point that especially in bifurcation PCI, the role of imaging is extremely important, irrespective of whether it's done before or after. I think it should really be used routinely for all forms of bifurcation PCIs, whether it's for the left main or non-left main PCI. I think the importance is actually paramount in both the subsets of lesions as well. So with that, thank you very much for your kind attention.
Yes, so thanks, Dr. Lee, for your nice presentation. Sorry that because we are behind the schedule, we have to save the Q&A after the next talk. So the next talk, go back to a speaker from Singapore, who is the Dr. Pham Giang Minh. He's from National Heart Center, Singapore. His topic will be how to choose OCT versus IVUS in bifurcation PCI. So Giang Minh, please.
Thanks very much, Dr. Tam, for the kind introduction. Can everyone see my slides?
Yep.
Yes.
Okay, all right, thanks. So bifurcation lesions are encountered in approximately 20% of all PCIs, generally constitute a more complex group of lesions, with lower procedural success rates, higher rates of adverse outcomes. We now have imaging modalities, initially IVUS and now OCT as well to guide us. Now here with two options available, how does one decide between the two imaging modalities? The next few minutes or so, I'm going to share some thoughts and discuss about the usefulness of both IVUS and OCT in bifurcation PCI. So some general considerations in bifurcation PCI first. Generally, stent malposition and underexpansion can be more commonly found. Side branch balloon inflation increases the risk of contralateral stent malposition. Stent mismatch between the proximal and distal vessels can lead to underexpansion in the proximal stent segment. And proximal stent malposition also increases the risk of abdominal wiring. Now, this table shows a broad overview of IVUS and OCT. Traditionally, with IVUS, which is ultrasound-based, it has greater tissue penetration and translates to a greater advantage in imaging larger vascular structures such as the left main. Higher resolution images is now made possible with the advent of high-definition IVUS. However, ultrasound-based are unable to penetrate calcium well and hence unable to determine the calcium thickness. Now, more recently, of OCT, which employs the use of light in obtaining much higher resolution images of the vessel architecture and thus better in detecting dissections, malpositions. It has a faster pullback speed. It has a lower tissue penetration, however, but it's able to penetrate calcium better than IVUS. Its main drawback remains in the fact that it relies on contrast clearance of the lumen. And this figure just shows images derived from high-definition IVUS at the top half that correlates closely with the bottom half that's derived from OCT images when it comes to assessing tissue composition of the vessel wall, be it lipid or anatomic structures such as side branches. Now, in regards to the comparison of IVUS versus OCT bifurcation PCI, generally, I think that advantages of IVUS lies in the fact that it does not need contrast clearance. IVUS is generally more available and backed by extensive experience which shows that it's safe and effective. It has greater tissue penetration and, which as mentioned, easier to access larger vessels such as left main. Its main disadvantage lies in the fact that it's lower resolution, slower pullback speed, and cannot penetrate calcium well. In comparison, OCT has much higher resolution, which provides much more potential advantages over IVUS over specific steps in bifurcation PCI. For example, improving the visualization of the site of the guide wire crossing and stent modernization tools. You can identify the wire position and strut, calcium thickness, stent opposition better. It has been shown to have greater sensitivity for detection of stent-related problems, be it dissection and malposition, thrombus, or tissue protrusion. Its pullback speed is faster and offers automated lumen analysis and co-registration, which is especially useful in double bifurcation stenting. Now, disadvantages include the fact that you need extra contrast clearance, and bear in mind that the amount will be amplified if you do bifurcation PCI. We need to do pre and post bifurcation stenting in both branches. Flushing is necessary to achieve contrast clearance, and sometimes pre-dilatation is necessary to facilitate the contrast clearance, whereas this is less required in IVUS. Less tissue penetration is an issue, especially in large lumen vessels and predominantly lipid composition. Now, in general, I think that both modalities have pros and cons, and choose the one that's most familiar with and can give the most optimal result. Now, lastly, even though much has been described about the fact that there's less clearance that's obtained with osteo left main lesions, this issue can potentially be overcome with the use of the guide extension catheter. Now, the higher resolution of OCT can help to determine the precise wire location and the relation to side branches, as such able to provide greater insights into the possible risk of side branch complication compared to IVUS. In this study published in 2014, with 49 patients with 52 bifurcation lesions were studied, side branch complication occurred in 22 lesions. And on OCT, a coronary tip angle that's narrower than 50 degrees and a short length between the branching point and the coronary tip being 1.7 millimeters represent the two best cutoff parameters in predicting side branch complication. IVUS can also detect anatomic features which may favor double stent over single stent strategy. Now, this image shows a spica coronal eyebrow sign seen on a longitudinal pullback reconstruction of IVUS that predicts coronal sheath or restenosis if a single stenting strategy is used. The study by Dr. Kang shows two IVUS predictors of functional compromise of the circumflex. In this norm study, looking at 43 left main bifurcations with osteodiameter stenosis of less than 50%, the FFR in the circumflex was actually measured after left main stenting. IVUS pullback of both the left main and the side branch were also performed. And in summary, two parameters, which is the pre-procedural circumflex of the osteo MLA being less than 3.7 mm square, and the higher pre-plug burden of more than 56%, represent two predictors of post-stenting diminished IFFR of less than 0.80. In another study presented at TCT 2020, IVUS predictor that predict beyond left circumflex stenting include a smaller osteocircumflex of less than 4.5 mm square, calcified nodule, and a layer plaque at the distal left main. Other than predicting sub-branch compromise, the OCT is a useful tool to guide rewiring in bifurcation PCI by recognizing accidental abluminal rewiring and assessing the position of the recrossing wire. There's this study that was in Eurointervention that shows that a significant reduction of multiple stent struts in patients undergoing elective treatment of bifurcation lesions under OCT guidance would be lower. Right? It's a relatively small study though. In the OCT guided arm was 12 patients with a control arm of 40 patients. This is an example of a reconstruction view of the bifurcation mode using Optis catheter. The Optis catheter automatically recognizes the carina as well as the side branch and assess the relation of the side branch orifice in relation to the main branch, determine its strut position as shown here. The stent roadmap shows the position of the minimal lumen area, recognizes the proximal and distal landing zones for stent placement based on mean lumen area measurements. And reconstruction from the automatic lumen delineation evaluates strut position, automatically detects malposition. This slide shows the different manifestations of calcium and their appearance on OCT and IVUS. Because light is not attenuated with calcium, OCT uniquely has the ability to measure and to characterize the thickness of calcium in heavily calcified stenosis. IVUS-based calcium score characteristics associated stent with extension includes a superficial calcium angle of more than 270 degrees, or that's longer than 5 mm lesion length. A necking ring of superficial calcium, which is like 360 degrees, and a vessel diameter of less than 3.5 millimeters. Now, the higher calcium score, as seen in OCT, implies more aggressive lesion preparation, implying that more aggressive modification is required. Calcium fractures, as seen on OCT, following lesion preparation, is associated with improved stent expansion. Now, the OCT calcium score is based on the presence of a wider calcium angle that's greater than 180 degrees. Calcium thickness is greater than 0.5 mm, and the calcium length of more than 5 millimeters. So as is seen in this study by Dr. Fujino in 2018, the higher calcium score is associated with greater risk of stent under expansion, malposition, and failure of device delivery. Post-procedural imaging can detect stent-related complications which may not be readily apparent on plain angiogram. The image on the left shows stent apposition as seen on IVUS. The data on adequate left main stent expansion are available from IVUS as well as seen on this right-hand panel, which can help us determine if the adequate stent expansion is achieved using specific target areas. We all know about the established IVUS criteria from Dr. Kang, this Korean study, which shows that IVUS-derived minimum stent area predicted angiographic restenosis and the target area of 5 mm square for the circumflex, 6.3 for the LAD, 7.8 for the polygon confluence, and lastly, at least 8 mm square for the distal left main. In terms of clinical trial, the ultimate trial is an all-comers randomized controlled trial involving almost 1,450 cases with almost 2,000 lesions, of which 25% were bifurcations. So as you can see here on this right-hand panel, the IVUS-guided PCI was associated with a significantly lower target vessel failure rate of 2.9% versus 5.4% in the angiographic arm. And recently, 3-year outcomes of the ultimate trial were presented in TCT as well, which showed that the lower target vessel rates seen in IVUS-guided PCI lasted beyond 1 year, up to 3 years post-index procedure. The randomized evidence for OCT-guided PCI is emerging as well. The doctor's trial, as presented earlier, showed that OCT-guided PCI improved post-PCI FFR compared to angiographic-guided PCI. Element 3 showed that OCT is non-inferior IVUS with respect to the primary endpoint of post-PCI minimum stent area. The OCT resulted in fewer untreated major dissections compared to IVUS and fewer areas of major stent malposition than both IVUS and angiogram. And last but not least, we have the opinion trial, which shows that OCT-guided PCI is comparable to IVUS for the endpoint of target vessel failure at 1 year. And the data actually lays the path forward for possibly what lies ahead for Illuminate 4, which I think has actually completed recruitment and probably planned for presentation soon. Okay, all right. We didn't discuss it beforehand, but I guess I'm mindful of the fact that I'm being at least the third speaker to talk about October. So while OCT offers advantages that could translate into improved clinical outcomes, it's still unknown if routine systematic use of OCT during complex bifurcation stenting will improve clinical outcomes. The ongoing October study is a large randomized trial aimed at studying the clinical outcomes, 2-year MIS, of whether OCT-guided stent implantation compared to standard angiographic-guided implantation in bifurcation lesions would translate to improved clinical outcomes. And the protocol, which I actually place here, is actually seen here. It's actually quite an elaborate protocol to follow. So the calculated sample size, from what I understand, is about 1,200 patients. A positive outcome of this October trial may establish OCT as a routine tool for optimization of complex PCI, whereas a negative result may indicate that OCT remains a tool for ad hoc evaluation in selected cases. So what does the latest consensus statement say? Now, the selection of a preferred imaging modality should reflect operator experience and the primary objective of assessment. IVUS is considered the gold standard for left main, and pullback in both the main vessel and the side branch is recommended for 2-stent procedures. OCT is feasible for distal left main lesions, as illustrated by the excellent case earlier on, and OCT provides a superior evaluation of stent and wire positions. OCT combined with angio co-registration and sophisticated real-time analysis software provides real advantages for stepwise bifurcation approach, especially 3-dimensional reconstruction to facilitate guide wire recrossing towards the side branch. Intracoronary imaging is available too in PCI on bifurcation lesion and left main, since it facilitates technical planning and optimization of the final result. And it should be available in the cath lab and is recommended that it's used when faced with procedural complications or unexpected technical challenges. Now, I actually prepared 2 case examples, but I think in view of the time, I should come to the conclusion first, and if you have time, I will just present the cases subsequently. So in summary, intravascular imaging is essential if we want to understand the true bifurcation anatomy and optimize outcomes. choice of either imaging technique depends on lesion characteristics, be it the location of the lesion, calcium composition, size of the vessel, and operator preference. The use of multimodality intravascular imaging systems, potentially combining either multiple imaging systems and or physiological lesion assessment, may hold promise in further optimizing bifurcation PCI. Further studies such as the Union 4 in October may provide more data on the usefulness of imaging in bifurcation PCI. And with that, thank you very much for your kind attention.
Dr. Pham and Dr. Lee, thank you for actually two beautifully complementary presentations. If we focus on your conclusions, firstly, Dr. Pham, you're very much kind of re-emphasizing what Mirvat had said about selecting the modality you're most comfortable with. So we've seen a lot discussed this afternoon, and there is complexity to this. And so I think being comfortable and confident with the technology is essential to get any information out. You highlighted some criteria, 8765, and kind of added the caveat that that is for an Asian population. I wonder, how do you, if you are using IVUS and or OCT, do you have to use different numbers? How do you go about achieving optimization? Do you use a relative expansion or an absolute value? And how do you do it in your clinical practice?
Thanks very much, Dr. Johnson, for your kind question. I divided it into a scenario of either the left main bifurcation or a non-left main bifurcation, actually. Well, in left main bifurcations, we all know about the established criteria by Dr. Kang. So I tend to use the IVUS criteria. Then I understand that actually there was an Excel sub-study, all right, that was presented in TCT a couple of years ago, which I think Dr. Mahera may be very familiar with, that potentially even achieving a target area of 10 mm square might have been possible in the larger size Asians or Caucasian. With regards to a non-left main bifurcations, it all depends. I'll defer to the European consensus statements, which use either the 5.5 mm square for IVUS or 4.5 mm square on OCT. But bearing in mind that that the caveat is that it all depends on the location of the target as well. I mean, it might be difficult to adhere to these targets in, say, for example, a smaller caliber vessel or a distal vessel such as the LAD. So in that case, there may be a relative expansion index of 80% or greater, or if possible, more than 90% expansion index on the OCT would be preferable.
Okay, brilliant. That's a really clear response. And actually, so you mentioned the consensus from the EBC, which I was part of, and I'd have to be critical of the fact it's very soft, and it says to use it if you like it and if you're confident. And we need to be slightly more bold in our opinion there. OCT, the October and Illumium 4 hopefully report at ESC in Amsterdam in August. So this is a really exciting year from an imaging perspective. Vincenzo, you've got your hand up for a question.
Yeah, thank you, Tom. And congratulations to everybody so far for the very, very excellent presentations. Now, I would like to address a point which has not been really touched yet, which is that one of the biggest temptations for us interventional cardiologists is to say, okay, I can nail the ostium when treated in bifurcation. Now, how can intravascular image debunk this myth? Because I believe that is a myth, according to my experience. And what are the evidence from this point of view?
Who wants to take that?
Yeah, I think like the two things. One is how you are confident where the actual ostium is. To answer that question, I think the imaging is quite helpful, and especially using the IVUS OCT, marking where the exact ostium, and then using that as a reference to consider what's the exact ostium. So knowing where, that's one important. And second is movement of the patient itself. So even you know where, it's many times patient is moving, so we have to confer. We have to work with the patient together. Meaning, if patient breathes a lot, changing a lot of location, those are the actual technical difference. So we have to consider two things.
Yeah. And actually, Frankie showed beautifully in his case another element, which is to understand the bifurcation from both side branches in the left main in both main vessels, LAD and circumflex, because you will get a different perspective dependent on how oblique the catheter may be cutting through the distal left main stem. We move on to another presentation on side branch, but I just want to pick up a point that Dr. Lee mentioned in his presentation, which was to kiss or not to kiss in the left main. You offered the question, but you didn't give an answer, Dr. Lee. What's your practice in terms of left main jailing and the need to clear the struts? Do you just use the imaging, or would you just take a kind of mandated approach to kissing all left main?
So the point I was alluding to was actually for performance of provisional stenting. So looking at some of the reports that are published in the literature, I do have a tendency of performing kissing for provisional stenting. But of course, that will also depend on what I find under the imaging side of things. If it was exactly like what it was for the first case, then of course I will not perform. So I think this kissing balloon inflation is very much driven by what I see with imaging.
Yeah, I think that's so obviously the original bifurcation trials, the series from Aarhus, which is where October is derived from, but the Nordic 4 trial was assessing kissing against not kissing, but it was really non-left main bifurcation. And although that showed equipoise between kiss or not, those images you show from those Indian case reports, which were embedded into the EBC consensus of endothelialization and coverage of the circumflex, I think are so emotive that not to clear struts from such a sizable side branch seems not sensible. With that, let's move on to the penultimate presentation, which is around how to use imaging in rewiring of the side branch, which extends nicely from this discussion. So Dr. Choi from Hong Kong, if you could share with us your thoughts.
So thank you very much for a kind introduction. So can you see my slide and hear my voice?
Yes.
Okay, that's great. So I was given a very specific topic on how to use imaging to guide side branch rewiring. So for guiding side branch rewiring, I think only OCT has the resolution to do so. So what I'd like to do is to change my topic to when and how to use OCT to guide side branch rewiring with case illustration. So previous speaker has having a good discussion on the use of OCT in bifurcation. OCT is very useful in determining morphology of the plaque in the side branch, lesion length, vessel diameters, and you can also predict side branch occlusion by using the carinal tip angle and also the branching point to carinal tip length. And you can also do 3D OCT because only OCT can give rise to clear resolution of the side stent struts, the length, and also the position of the side branch recrossing. You could also have a higher resolution to a better resolution than IFRS for monitoring of post-stenting complications such as media dissection and or hematoma formation, apposition, and also stent expansion by using the Illumin 4 criteria. So with that, I would like to go into my cases. My first case is a 79 years old non-smoker, history of diabetes, end-stage renal failure, failed renal transplant on hemodialysis. He has a 3-time PCI done in private hospital and detail was not known. And he was admitted for end-stage ischemic APO, high sensitive troponin was elevated, ST depression and trilateral leaks and congestion in the chest X-ray. So this is the corneal angiogram. You can see distal left main is moderate to severe disease, and there's stent in the left main and also the circumflex. And you can see the LAD and circumflex are stented, as well as the RCA are full metal jacketed. And the distal left main is severely diseased. And you can see an eccentric lesion in the distal left main and also the proximal osteal LAD. So the right coronary, there is moderate stenosis in the osteal RCA. and there's a PLV branch was CTO, and the PDA is patent. So I proceed to PCI. So I go from femoral 7th French EBU 3.5 guiding. So I attempt wire into the LAD, but I fail despite with 10-15 minutes of wiring time. So this is unbelievable. So it seemed to be a very simple LAD lesion, but I cannot wire with even 10 to 15 minutes. So I changed to another view and still failed to wire it integrately. So I did a OFDI and check. So I will let the OFDI play. So you can see this is the stent from the circumflex. You can see the stent struct is still the stent struct is still uncovered. This stent struct coming here is covered by the neointima. And this stent struct is uncovered despite the PCI was done many years ago. And coming all into the LAD. So you can see here is the LAD. The LAD is at 6 o'clock. You can see a tissue flap covering the ostium of the LAD. So I will show you once more. So this is the circumflex stent. So this is the LAD at 6 o'clock. There's tissue flap covering the osteo LAD. So this is still images. You can see the OFDI pool is from the circumflex. And this is the LAD more distally. You can see a tissue flap here. And actually it's covering the circumflex and the circumflex here, and also the tissue flap covering the opening of the LAD. So this is the diagrammatic representation of what I found from the OCT. So the LAD is actually a little bit retroflex relative to the cert, and also there's a tissue flap covering the ostium of the LAD. So with that in mind, I think reverse wiring is the only solution to this case. So I do a Kawasaki technique, use the Kusei dual lumen catheters and reverse wiring technique. I successfully wire into the LAD. So mind you, this is first few case I did, so I spent some time. So the movement is actually reversed. When I want to advance, actually is to pull back the guide wire. So with some time, I successfully wire into the LED like this. And then I pull back the wire so that the wire jump into the LED, but I cannot push further because the wire keep prolapsing into the circumflex. So then I use a trap balloon to exchange the dual lumen catheter out, and then I pass a turnpike into the LAD, and then I exchange to a workhorse wire. And I did the OFDI and stent the left main to the LAD. So this is the NC balloon. There's some waste in the ostium of the LAD. So I use an OPN balloon to predilate, and then I put a stent from left main to LED. And this is the final result. So actually OFDI gives some insight of the bifurcation and help us to do the rewiring of the what you call the side branch. That is, in this case, is the LAD. So case 2 is a 66 Hep B cirrhosis, HCC with hepatectomy done, hypertension, DM, and also ischemic heart with positive treadmill. So this is the target of today, the left LAD and D1 bifurcation. So this is another view. So if this LAD D1 and Medina 1 011 or 111 bifurcation, so you can see that the angle of the bifurcation is very narrow, less than 50 degrees, and also diffuse disease in the D1. And there's a high risk for side branch closure. So I decided to do the two-stent technique. So I do pre-dilatation and then OCT of both side branch. And then I do stenting to the diagonal first, and then balloon, and then do the mini crush in this case. The standard, the proximal to mid LED. And then I do the first rewiring. So I can feel a slight resistance in wiring, and I found difficulty in passing a used balloon. So I check with OCT. So most of the time, if you wire through a small struct, you will have some resistance. So this is the first wiring of the stent struct. You can see the wire is actually going through the small cell of this side branch. So actually, the more optimal rewire location would be more distally. So I perform the second rewire with the first wire at the guiding position. So I perform the rewiring to more distal location. And then I check again with another 3D OCT. So the second wire actually go through the optimal cell. So I'm pretty comfortable to do a kissing balloon here. So and then perform the kissing balloon infusion. And I recheck the OCT. And then you can see actually this cell opening is very nice. And this is the final angiograph result. And third case, similar case, 67 non-smoker, hypertension, ischemic heart disease with CT cornea angiogram showing significant LED, SIRT, and also RCA disease. Fixed the RCA, and this is the LED bifurcation lesion. So you can see actually significant lesion in the proximal LED and also the osteo diagonal. You can see actually the plaque is protruding and partially covering the ostium of the diagonal. So if we stand across only the diagonal, there may be a chance of closing off the large diagonal branch. So again, I decided to protect both branch and also do two stent technique in this case. So I OCT both sides and also the main branch. I think this is a must if you do bifurcation stenting, is to image both branch. So I intended to do the DK crush initially, but perhaps I do not protrude my stent enough. So I rewire and then do the kissing. So when I do the stent boost, I actually noticed that my stent is actually only slightly protruding into the LED. So my first rewire is actually go through proximally in the same position as the first wire. So actually, this is not DK crush, but maybe nano crush because the stent is not protruding way into the LED, and actually my wire actually go through the original wire position. So I put the stent in the LED across the diagonal, and then I rewire it. So I rewire, I do cine and also make sure that the stent rewiring is not at the very distal part. So at distal part, you have two layers of stent. So you don't want the stent, the wire to go through two layers of stent. So perhaps more middle or proximal, mid recourse would be the best in my case, because this is only slightly protruding into the main branch. So I then check with the OCT to make sure I'm in the optimal cell. So in this case, you can see actually the link is connecting to the carina. So this is a link connecting type, and it's a proximal recross. But if I do a distal recross in this case, perhaps I may cause a distortion of the stent struct. So I will accept this Y location and do the kissing here. So I do the kissing balloon infusion and we check the OCT. And then you can see actually I can clear most of the stent struct more proximally. And for this overhang distal struct, perhaps we can do nothing on it because there's a link connecting to the distal stent. So if I wire to this cell, I may cause distortion of the main branch stent. Perhaps it's doing more worse than good. So I accept this result, and this is the final angiogram of this patient. So nowadays I do more and more nano crush, and some may vary missing the ostium, but sometimes I'm protrude only slightly into the LED, and then I do the main branch stenting port, and then rewire and kiss with the result of like this. And for DK crush, you need to protrude a little bit more, and then you recross proximally and open a hole to facilitate second kissing, and then you do the main branch stenting port, and then rewire and kiss. So the rewiring, you should not go to the very distal because you may be going through two stent, and maybe the middle or part of the stent may be the best. So the last case I'm going to show you is a 53 years old inferior STEMI, given lytic. So this is the bifurcation lesion, and I Y and OCT both branch, and you can see this is the pullback from the PLB branch. So you can see lipidemic plaque with evidence of plaque rupture here, and the very tight lumen, and this is the PDA wire coming in. So this is the OCT run from the PDA. So also with significant tight lipidemic plaque, but this time the fibrous cap is thicker and there's no evidence of plaque rupture here, but I think this is significant as well. So I do again nano crush in this case. I stented it, and then put another stent across. So, and then I rewire the PDA. So most of the time, you don't need OCT to confirm this is proximal recourse, because from angiogram, you know this is proximal recourse and you don't want this kind of recourse. So I do a more distal recourse. I usually don't want the very distal part, because some of the stent struct may got, compressed, lift up by the main branch balloon. But in wiring of this without any resistance, so I think perhaps this stent is not protruding into the main branch as much. So this is a distal recourse. So I perform kissing balloon here, and then I check the OCT. So you can see there's some under expansion in the proximal part. I finally touch with a 4O NC balloon here, and from the 3D software, you can see that the side branch opening is really nice, and there's no overhang stent struct in the side branch. So this is the final angiogram. So OCT allow accurate sizing of the vessels, plaque burden, plaque characteristic, and sizing of the main branch stent should be according to the distal vessel to prevent the Carvana shift. Port is very important. And OCT allow careful evaluation of the wire position after stent rewiring to ensure optimal side branch recrossing, and also exclude accidental rewiring outside the stent. So I would like to skip this part and jump to the conclusion. So I must say I do not routinely do OCT to check side branch recrossing. So I would rewire second or third time if I feel resistant in the side branch wire, or if there's difficulty in recrossing with a new 1.5 or 2.0 balloon. And sometimes I would perform OCT check if the side branch rewiring is not easy, or if I have done several times and still feel a lot of resistance and I cannot pass through the balloon. I make sure that my rewiring is not in the small size, more cell of this stent struct. So if OCT confirm an optimal cell crossing, then I will use a smaller balloon like 1.0 balloon or even anchor balloon in the main branch to increase the support and do the bifurcation and kissing balloon stenting. And thank you very much for your kind attention.
Thank you very much, Dr. Chee. That was a very practical kind of talk, a bit different from all our previous very theory-specific kind of talks. And I quite liked how you made it sound very practical when to think about using imaging, because it's probably not I wouldn't say not necessary, but practically not every one of us uses imaging every time we need to recross a branch. So just being practical, let's say you in one of your cases, you mentioned you tried for 10-15 minutes before you decided to try something different. So if let's say you did discover that you were in a suboptimal cell, a proximal cell, and there was a distal cell that looked more appealing, for most of us, just rewiring a side branch, we treat that as a success. How hard would you try? How much more time would you then invest into trying to get that perfect distal cell or that perfect looking cell that you find on imaging?
Yeah, I agree that sometimes it's not easy to do. I may use a dual lumen catheter on the first wire to make sure that I'm not wiring in the same hole. So that may be, if I say it's a distal cell, I try to use the first wire as a marker. If I try multiple times, go through the same hole, then if money is not concerned, I use the dual lumen catheter on the first side branch wire to make sure it's not crossing in the same hole. Because if you wire the same hole, you can pass through the dual lumen catheters. If you wire different hole, you cannot pass through. Then it signifies that you are in different cell. And then I confirm with OCT before I do the ballooning. But I must say, because the routine, PCI is very pressing. In one day, there may be 10, 20 cases waiting. So that you don't have enough time. So with experience, you know that your wire is in a small cell just by the wire feel. If you pull back or advance the wire, you feel resistant, then your wire, the cell crossing is not optimal. Then I would use the second wire to rewire. Make sure it has a free rewiring before I do the ballooning. Or if the balloon a new balloon cannot cross easily, then there must be the cell crossing is not optimal. Then I would do the rewiring. I routinely, I don't do a lot of OCT in checking, to be frankly speaking.
Yeah. And you mentioned, all your cases with OCT, you changed the topic, the title of the talk to OCT instead of imaging. And obviously you're leveraging on the 3D reconstruction function of OCT. Do you or anyone of the panel think that we can, with IVUS, have a similar sort of confidence in selecting a cell for rewiring? Anyone got any?
I'm happy to say no, I don't think we can, but I think we have to have a reality check. We wait for the data from October to show whether this does make a difference. I have to say, in my practice, in a complex bifurcation, I will use OCT and I will try and get a distal cross. And I don't believe that no matter how experienced you are, you know where the wire is just by feel. We can be kidded by how the devices feel in our hands. But I think until we have the data, we need to be cautious about saying that everyone should be applying these techniques, because it takes a huge amount of time and experience. And so it's more about the other elements of bifurcation PCI that are going to make the biggest difference. So as you highlighted, Dr. Chee, proximal optimization is critically important. Sizing with your imaging probe to know the proximal and distal vessel size, and selecting the right device that will have the expansile capacity in the proximal main vessel. There are other aspects to the bifurcation that we probably need to prioritize, and this is true optimization and taking it to a level of perfection that in many situations we don't have the time or luxury to kind of expend energy on. But that's just a reality check from my perspective, I think.
Yep, I probably would agree 100% with that. Okay, I think we should move on to the final, last but not least, but the final talk by Dr. Lucio Padilla, who will give us another recorded case. Please, Lucio.
Thank you. Thank you very much. Do you hear me? Do you see it?
Yes, perfect.
Okay, so the idea is to show something, how to simplify a complex unprotected left main calcified PCI. So the idea, I'm trying to move the, I can move the, so the idea is to show this case. So this is a male, 68 years old, dyslipidemia, previous PCI to CIRC, and nowadays with angina and a stress echo with anterior ischemia. If you see here, he had a renal insufficiency. So here, one of the things that I try to do in this type of patient, I want to do the less contrast that I can't do. I want to do something that give me a lot of information. In this rotational angio, this is a tool that I use a lot in order to see in this type of left main, LAD, and trifurcation lesion, what about this? And I choose the image that I want to work or to assess or to analyze with this. So then I can do a cranial rotational tool, and I choose in this way, for example, where I can see the distal left main, where I can see the proximal LAD, what about the calcified lesion here, what about the side branch, and what about in the other view in order to see the trifurcation lesion. So here we have a patient with anterior ischemia. Perhaps I see something here, something in LAD, or I have to assess and to be very comfortable to work with this. So first of all, how to assess this patient. I'm going to see, we put this patient always in the heart team, but we try to do IVUS guided unprotected left main PCI. I think there is no issue to do FFR in a patient with angina, anterior ischemia. and coverage is not an issue here for us when we try to do this. So this will be radial approach, femoral approach. You have to feel more comfortable. In my cath lab, we try to use as a radial approach in most of the cases, but in some cases we can use. And in a trifurcation, perhaps you have to use 7 or 8 friends because perhaps you have to finish with a tracing or not. Here I choose a 7 friends extra cap. And I choose to wire LAD and CERC and not to go to the intermediate ramos in this case, and to do the IVUS assessment as the most important thing to decide the plaque modification with no compliant balloon or with rota or with IVL, and to try to do provisional stenting to left main LAD, knowing that I have a diameter mismatch from LAD to left main. So here is the IVUS, and this is the distal LAD from here. So what I am looking for the IVUS, I want diameter here in the LAD, in the landing zone, so to do a bookmark here to see which is the size here in the LAD, which is the size here in the left main, which is the size here in the distal left main, that about the left main. Then the length of the lesion, then the morphology and the type of plaque. This is a calcified plaque. This here we have a concentric plaque. We have different plaque, concentric plaque, eccentric plaque, nodular plaque, deep plaque, superficial plaque. So these are all the information that I will have from this IVUS. So here I have an eccentric plaque here, a calcified plaque here. Here I have more concentric plaque. I know the minimal luminal area. Here's the ostial LAD lesion. Here the distal, the ostium LAD and the CERC, the opposite plaque. It's very important here for me to know if I have a plaque, a concentric plaque here, or a plaque that compromises the CERC or the trifurcation. So in summary, we have a proximal LAD, concentric calcified lesion, 3.8, 3.9 diameter in the proximal LAD, ostial LAD, 4 millimeters, distal left main, concentric calcified plaque, left main diameter 5.9, 5.8. So this is for me very important to see if the distal left main compromise or not the CERC. And what about the concentric plaque, and what about how to manage this type of plaque. So plaque modification, this is the second thing that I have to think. After the IVUS assessment, all the information to the plaque modification in this. No compliant balloon, rotablation balloon, IVL balloon. If I have to do in a trifurcation, I want to rewire more or less less LAD and CERC, and perhaps in some cases, if I have a compromise of the trifurcation because of the distal left main plaque, I will put a third wire. But in this case, I will try to put 2 wires and to simplify the case, and because the minimal luminal area with no compliant balloon, first of all, and then to IVL, and to try to do provisional stenting to left main LAD. So in this case, what about the difference between IVL and non-compliant balloon? The deep calcium is very good trade with non-compliant balloon. No, I think that we need in this case IVL. What about the risk of complication? Very low in both of them. And the effectivity, I think what IVL is better than non-compliant balloon, but we need the non-compliant balloon from the beginning. And if I compare IVL with ROTA, perhaps the deep calcium with the ROTA, I couldn't go with it. Risk complication is low with IVL and intermediate with rotational, maybe effectivity good for both methods. So this is the IVL in LAD and left main, 3.512. So, and here we have the, what about the IVUS assessment post shockwave here, and because of the time, I'm going to show some imaging, but we have some cracks here in the LAD after the IVL, in the proximal LAD, in the LAD ostium, and so this is what shockwave do in this case. So pre-IVL, you can see in the distal left main and the circ, and we can see how it tracks the plaque. So now about what technique to use, I was thinking about provisional stenting regarding what about the left main and compromising or not the circ, and I can see the ostium of the circ free of plaque. So I try to put the first stent, a synergy 1 in the LAD, and then I try to use, if I can, a dedicated stent for left main, like the Synergy Megatron, that these are 428, that here is a stent boost that I did in this case, but I choose because I have better radial strength and radial force here, and I can go with this stent from 3.5 or 4 to 6, and this artery that have a mismatch 3.9 in distal LAD and near 6 in left main is a very good thing to do a very good expansion and visibility and scaffolding, and this is very important, no? Because after the pod, if I need, I can do a very good 5 millimeters size to do the side branch access. So here the angiography report, you can see this is the after the stent, the Synergy Megatron. Here you can see the pre-pod, and here you can see the very nice imaging, left main LAD, the trifurcation, intermediate ramos, circ, and here you can see the Megatron, very good, the mismatch, here 6 millimeters, 4 millimeters here, calcified plaque here. So these are very good imaging, and this is the final result with IVUS. And because of the time, I will show this very good thing. What I'm looking for the IVUS, I want to see no dissection here after the stent, well position, symmetry, very good lumen area in all the stent, and try to do the 5, 6, 7, 8 minimal lumen area in all the stent and the treated left main LAD lesion. So this is an example how to choose with IVUS the better tools. I think the IVUS assessment guided PCI is very important in order to choose afterwards if IVL or ROTA, always no compliant balloon, to try to do provisional stenting because of the IVUS assessment, and to choose the stent that I want to use in this because of the diameter mismatch of the left main LAD. Renal and radiation, try to do the less of contrast, to do coronary road mapping, rotational angiography, to choose the better information or that to work in this scenario, to use stem boost technique as a complementary. For plaque optimization, to IVUS assessment, to do IVL in this type of plaque. IVL, stem boost and haste to see as a complementary of IVUS, to do a provisional stent in this way. And we are putting all this data in the latent bifurcation registry. So thank you very much. And if you have any comments, Thank you.
Frankie, you're on mute.
Oh yes.
Sorry?
So thanks. Yeah, thanks, Lucia, for your great case. So, Dr. Akiko, you have any comment?
Yeah, so I have the question. I think like the nice case, really nice and good usage of the IVUS. But my question was, how do you do side branch IVUS directly before and after in such case? The question was, because when we analyze the bifurcation plaque distribution, most of the time we see the plaque from the main branch, meaning from the distal LAD to the left main. Always we see the plaque. But there is much more variation in terms of the side branch plaque, meaning sometimes circumflex totally clean or sometimes continuous. So to me, the side branch IVUS is actually more important than main branch to decide what to do for the bifurcation. So my question for you is, in a very nice case, what do you do the side branch IVUS in such case?
Thank you, Akiko. In this case, I think that if you have from LAD to left main an IVUS assessment and you don't see a very important ocean circ or intermediate ramus plaque, I will not going to do the IVUS assessment. If I have any doubt about having any plaque in intermediate ramus and circ, I always do previous the case and IVUS in order to have the diameter, the type of plaque, the eccentricity, the concentric, if the calcium is superficial, medium, or nodular, and to planify what I'm going to do. So in this case, I try to do only 2 wires to do modification of the plaque, and I know that I probably I will not going to have shifting plaque to circ or intermediate ramus because of what I assess previously with the IVUS. If I have any plaque in intermediate ramus or circ, I always, after doing the plaque modification, we reassess IVUS in all the 3 branches.
Yeah, I agree. This case, circumflex ostium super clean by already left main pullback. So practically, I think I agree with you. Thank you.
That's why I didn't do IVUS in circ and intermediate ramus in this case. If not, always. I think this is very important for the fellow too. If you use IVUS, OCT, or whatever, use from the beginning, because all the information for the planification of the case is from now. So use the IVUS not after the stent, from the beginning, previous, to do all the assessment of the plaque that you need to modify and to have the better PCI and with no complication for the future.
Yes, James?
Oh, yes. Hi. Thank you, Lucio, for a great case presentation and great example of the use of IVL in a calcified lesion. My question, I guess, a lot of contemporary calcium algorithms recommend that if you could cross with a balloon, then potentially you could use IVL upfront. But my question is leading to the previous comment on calcified nodules. Not in this case, but if you saw a calcified nodule on your imaging, and even if you're able to cross with the balloon, would you use IVL to treat calcified nodule? Do you have any experience with that? And any comments, and perhaps Dr. Akiko can comment also.
Yes, thank you, James. I try to do, if I can't cross with the balloon, that sometimes may be because of calcify, I will try to do non-compliant balloon, and if it doesn't go, I do rota. But if I have the minimal luminal area, more than 2 with a concentric or nodal calcified plaque, I have to do a non-compliant or OPM or a scoring balloon or whatever, and then to do IVL. I do IVL, and I go until 4, and then I go until 6, and then I go with an OPN or non-compliant balloon until 22 atmosphere, trying to modify the plaque. But I don't know, Akiko, if you have any comment about IVL in nodular calcified lesion or not.
Yeah, I think when we look into the CAD, that's a registry based on the IVL and using the OCT as evaluation. In such a registry, we see if you're using the IVL on the calcified nodule, we see a little bit more like the disruption of the calcified nodule compared to regular balloon. But we don't know how this type of the disruption can help long-term outcome. At least like the calcified nodule in that cohort is only like 35 or 6. It's not super many. And at least in such limited number of the calcified nodule, when we see the long-term outcome is not super different compared, not bad compared to the historical cohort in terms of the calcified nodule cases. Meaning, typically when you have the calcified nodule, they are poor outcome compared to just severe calcium. But it's not super bad compared to the just regular super severe calcified cohort. So I would say kind of promising result, but I'm not 100% confident because the calcified nodule is a difficulty, is really long-term outcome. As I said in the beginning of this session, even though you have the very nice area at the end of the procedure, they are coming back. Sometimes that's causing the relatively quick instant restenosis instead of just restenosis. So how to deal with this type of eruptive calcium is actually more difficult to deal with. So we need more data. But I think at least when we are talking the nodular chunk of the calcium, like the Frankie's case in the beginning of this course, that's probably the best to use the debulking instead of the IVL, I guess.
Yes, thanks, Dr. Akiko, for your very nice comment of calcified nodule. I think nowadays we have many tools for calcified lesion, but I think calcified nodule is still one of the worst lesions we have to treat. I have many experience that the so-called eruptive calcified nodule, we put in stent, but the patient come back 3 months later, especially those patients with chronic renal failure or dialysis. Those patients just come back. I think that the nodule just grow inside the stent again and causing the ISR. So even we do the rotor, orbital, they still come back again. So, but I think this is really a challenge. I mean, probably the next frontier for calcified lesion for us to think the way to tackle. So, any more comments from our panelists or speaker? So I think time is running fast. So I think we have a very enjoyable night in Hong Kong. Personally, I learned a lot from all of you. So I would like to thank all the speakers, panelists, and also my co-moderator, Dr. Thomas Johnson and Dr. Chin. So thanks again for everybody. And I think the APSC, the Asian Pacific Society of Cardiology, has been organizing a lot of various webinars and also live course in these over the years that I think I enjoy a lot and I really learn a lot. And of course, this TCIP, the Transcontinental Club on Imaging and Physiology, will also be organizing various courses that we hope we can promote knowledge sharing, friendship building, and of course, learning for ourselves. So thanks again for all of you and hope you have an enjoyable weekend and we'll see you soon. Thanks very much. Bye-bye.
Thank you very much. Have a good evening, everyone.
Thank you.
See you all in Hong Kong.
Thank you.
See you. See you.
Bye-bye.
Bye.
Bye.